So we've completed the application of the immunology that we learned in terms of the cytokines and the workings of all those details that we spend so much time cramming into our head. Now there's just a couple more sections that are critical to go over, and this next one is about hypersensitivity. And I would guess that every exam that you're going to take in immunology or any board exam is going to ask you questions about hypersensitivity reactions. Now, hypersensitivity, when you first hear that, you think, oh, something is too much, and therefore too much of a bad thing, or too much even of a good thing is a bad thing. So yes, that's true, but realize that sometimes these hypersensitivity reactions are just describing what's just sort of naturally happening in the immune system. So let's look at each one of them. There's 4 types of hypersensitivity, types 1 through 4. So just keep it always as simple as you can and think of some key words, because every question, no matter how they convolute it, are going to have to include these key words. So you have type 1 hypersensitivity. And what this is there's 3 components that have to be present for it to be type 1 hypersensitivity. The first one, okay, is that it's IgE mediated. If you don't have an increase in IgE, then it's not type 1 hypersensitivity. The second one is that you have preformed antibodies, i.e. IgE antibodies. So you go through that whole antigen processing rigmarole, and you go through isotype switching, you end up with IgE, and lo and behold, you're sitting there with the mast cell with these IgE sticking here, and along comes, okay, whatever it was these are specific for that were presented before. Let's say, I keep saying the same thing, we'll just stick with it, a peanut, okay? Along comes some fragment of a peanut, and now this is going to cause a reaction, the mast cell, to degranulate, okay? And so in this case, you're talking about the second exposure. You had the first exposure to get the IgE, and now you got the second exposure. So again, 3 things must be present: IgE, preformed, and a second exposure. And this preformed, you may not even be aware of it, because some molecules sort of are homologs to each other. So you might not have thought, well, geez, I never ate that, but you might have eaten something that's similar, or maybe you were exposed to it at some other point that you were not aware of. Okay, so that's type 1. All right. Type 2 hypersensitivity, the magic words are it's antigen antibody mediated. So it's very clean. So for example, in the last section we talked about good pastures. Good pastures is an eponym for a disease where you get antibodies to the basement membrane. Okay, the basement membrane of the glomerulus, the basement membrane of in the pulmonary system as well, in the lungs. And it causes pathology. And when you look at the immunofluorescence of it, it's nice, this linear sort of just like beautiful paved road of this immunofluorescence, okay? And that is what they call antigen antibody specific, and it is a type 2 hypersensitivity reaction. Another type 2 hypersensitivity reaction would be Graves, but that is active, right? It's that antibody is acting as though it was a thyroid stimulating hormone. Another type 2 hypersensitivity reaction would be myasthenia gravis, where you have an antibody to the acetylcholine receptor such that acetylcholine is not able to bind those. So that would also be an example of type 2 hypersensitivity. So anything with an antigen antibody mediated pathology is going to be type 2 hypersensitivity. Now, type 3 hypersensitivity, the buzz phrase there is immune complex. Now this can be kind of confusing, so because you do have antigens and antibodies involved in this, but it's like a complex. And the way that I think about it is, it's almost like a lattice of all these guys sort of bound together, and they come up with this whole sort of schmutz of antigen antibody, and it's like a big lattice. All right, and as such, as such, it's not very easily cleared by the body. So remember that the red blood cell has a CR1 receptor, which is designed to sort of haul off the trash of this antigen antibody situation off to the spleen, to the trash can. But look at this. This is way too big. So what happens is, well, essentially not too big in size, but is too complicated for it to get rid of. So what happens is instead it deposits in the vascular space. So it's oftentimes implicated in vasculitis, or it might deposit in the glomerulus. So you get glomerular nephritis, okay? And instead of this nice, beautiful, linear pattern on the glomerulus, you see this lumpy bumpy because these big, chunky immune complexes are deposited there. Another thing that happens with regard to type 3 hypersensitivity is one of my favorite terms in immunology, and they call it the frustrated phagocyte. So what happens is, let's say that this monstrosity of an immune complex deposits in my nice, beautiful endothelial vessel. Okay, so imagine that it's sort of sitting there. And along comes a macrophage, and he's not happy about it, so he wants to clean it up. Well, he tries to, phagocytose that, but it's sort of fixed. It's deposited in this vasculitis. So he's like trying to get it, and eventually he just gets frustrated, and he just says the heck with it, and he just secretes all those reactive oxygen species. It actually happens, and as a result, it damages that endothelium, and then you get all endothelium damage and inflammation and yada yada yada, and that's how you get immunopathology. So diseases typically associated with type 3 hypersensitivity. We talked about vasculitis. Also, SLE is another disease. And some diseases can have sort of shades of type 3 hypersensitivity, shades of type 2 hypersensitivity as well. So it's immune complex. It deposits in vascular endothelium. It deposits in inopportune places, clogs up those kidneys, and causes renal pathology. So that's your immune complex. That's type 3. Again, it is antigens and antibodies, but it's not just one clean antigen and antibody. It's these complexes that can't be cleared. The phagocytes is one example, as they get frustrated and they start sparking off reactive oxygen species. Type 4 hypersensitivity, buzz phrase there is cell-mediated. And when we say cell-mediated, we mean T-cell mediated. So the T-cells have to be involved in this fight. Okay, so what are some examples of this? Well, first of all, you would have an example would be our friends of like poison ivy. That's a type 4 hypersensitivity, okay? You get exposed to it, and then it gets presented to the T cell, and then you get these welts on you. Another example of type 4 hypersensitivity would be a PPD test, and your MAN2 test, your tuberculosis test, okay? So that's another one. They inject you, and if you've had a previous exposure to TB, you're going to, within 48 hours, you're going to mount a response, and you're going to get, some inflammation of that particular area, and you're going to get over the 15 millimeters, etc. And they're, oh my goodness, you got the TB. So that would be an example of cell-mediated immunity. Hashimoto's thyroiditis is another example of T-cell and cell-mediated hypersensitivity, type 4 hypersensitivity. So keep these in the back of your mind as we go through the questions. And the buzz phrase, IgE preformed, second exposure, antigen antibody, immune complex, vasculitis, cell-mediated, okay? So keep those in mind. If you wear some cheap jewelry or something, that's also an and you get sort of little welts around your fingers or your earrings, that's also a form of type 4 hypersensitivity. Nickel is famous for that. So let's go through some questions. Number one is the hypersensitivity type and mechanism behind hemolytic disease of the newborn is which of the following? Okay, so this one is, if you remember, your red blood cells have antigens on them, right? You might have type A or type B, but you also have the D antigen, which is called Rh positive or Rh negative. And so in the case of hemolytic disease of the newborn, you have a Rh negative mother and you have an Rh positive baby. Okay, so that's the antigen, and then you create an antibody. The mother creates an antibody to that Rh positive or the D antigen. So that's antigen antibody. So right away, you know, let's keep that in mind as you look at the questions. A, type 2 hypersensitivity reaction because the mother developed antibodies to the Rh positive antigen on the RBCs when she had had a previous exposure to Rh positive antigen of a previous child's blood during childbirth or miscarriage. So what happens is, as you well know, there shouldn't be an IgM cross of mother to fetus, okay? But when you're in the womb, okay? But you do get a cross of IgG. Well, if you had a miscarriage on the first child, or if blood passes naturally in childbirth, it's a messy thing. So she's gonna get exposed to the little guy's Rh positive, and she will create antibodies to that. If they don't give her an anti-antibody, then they're going to be sitting there waiting for antibodies, waiting for that next child. Antibodies that can be potentially IgG at that point, and obviously cross into the placenta. So that's what happens in that case. So the answer is A. It is type 2 hypersensitivity. Number 2 is type 1 hypersensitivity is mediated by what? And we just went over that. That's the answer is B, is IgE. Number 3, the immune complexes of type 3 hypersensitivity reactions include the following. Okay, so what are they essentially? And the answer, large uncleared, no, that's not it. B is small uncleared complexes of antibodies and antigens that are agglutinate. Okay, so they coalesce together and are deposited in small blood vessels and basement membranes. That is classic. That's textbook vasculitis and glomerular nephritis. That's type 3 hypersensitivity and the correct answer. And then C is single antigen antibody complexes. That describes type 2 hypersensitivity. Number 4 is you're in Sub-Saharan Africa and suspect that your 18-month-old patient may be HIV positive. But you've run out of HIV test kits, which is not uncommon, okay? In fact, we didn't have any HIV test kits where I was 2 days ago in Sub-Saharan Africa. So, but you could test the patient's cell-mediated immunity by exposing her to what? Well, the idea here is, what have we pretty much all been exposed to in life? And you can think of this, if a little baby gets diaper rash, where do they typically get it from? From candidiasis. So all of us have been exposed to candidiasis. So if you expose a child to candidiasis, assuming they're over the 6 months or so, and they've got a good immune system, then they're going to have a reaction. But if the child has no reaction to candidiasis, then you can assume that they must have some kind of defect in their cell-mediated immunity. Cell-mediated immunity being the T cells. So that's how you want to think about it. You also always want to think about, for example, if you give somebody a TB test and they're HIV positive, or they're an older person, they're not going to mount that big, that big welt if they're HIV positive. That's why the requirement for the millimeters of having a positive PPD test are reduced for HIV and are reduced for immunocompromised people. Number 5 is another name for hypersensitivity reaction in question number 4 is what? And the answer is A, delayed type 4 hypersensitivity. Delayed because it takes a few minutes for the T cells to get their act together, not a few minutes, a few days, I'm sorry, and mount the appropriate response. Number 5 is Graves' disease is an example of what type of hypersensitivity, and we talked about that. That's a type 2 hypersensitivity, which is the answer is B. Number 6 is the lung biopsy of a patient shows a profuse granuloma formation with caseating necrosis. Sputum has acid-fast bacilli. A diagnosis of TB is made. Now, what kind of hypersensitivity reaction is this? And what type of T cells are responsible for it? Now, remember how I said with Mycobacterium, Mycobacterium leprosy, Mycobacterium tuberculosis, particularly Mycobacterium tuberculosis, you got an intracellular pathogen, and it's not easy to clear it. He drives around in like in an enemy tank, like I said. So what the body does instead is it mounts a Th1 response, and so you proliferate these macrophages that sort of surround it, okay, and it's called a granuloma. And so you have these you have the cells that are going to surround that particular infection, and then you have T cells around there that just keep throwing interferon gamma to enable those macrophages to continue to make the fight. And they there's a certain ring around it which is called Langerhans cells, but you get more to that in immunopathology, or not immunopathology, but in pathology. But the important thing here is that when you see granuloma formation, you're talking about a delayed type 4 hypersensitivity, and you're talking about Th1, and you're talking about interferon gamma is the most important cytokine to feed that fight. Number 7 is the immune response to Mycobacterium tuberculosis depends on the secretion of, and I just gave it away, the answer is D, interferon gamma. Number 8 is immunofluorescence reveals your patient has diffuse proliferative glomerulonephritis with immunoglobulin and complement deposition in the mesangium. It has a lumpy, bumpy characteristic appearance. This would be considered which of the following types of hypersensitivity? We went through that very clearly, and that's going to be, the answer would be a type 3 hypersensitivity, and therefore that is answer number C. So there's a complication with campylobacter is Guillain-Barré syndrome, right? So that's kind of common with regard to that, is people with this campylobacter can get Guillain-Barré. And it's believed that the pathogenesis of this disease is related to this antigenic cross-reactivity between the surface of the lipopolysaccharides of some strains of campylobacter and the peripheral nerve gangliosides. So the antibodies directed against specific strains can damage neural tissue in the peripheral nervous system. So what is the example of this type of hypersensitivity? So this is an antigen antibody mediated, and that's type 2 hypersensitivity. I did this question to kind of show you how sometimes they can get involved a lot with, describing a disease, but at the end of the day, you've got an antigen antibody, it's type 2. So number 11 is your patient is a 15-year-old who has had a kidney transplant 4 years ago, but he's now suffering from renal failure with diffuse fibrosis of the transplanted kidney. All right, so the best way to characterize this graft failure is to say it is what? Well, so we'll get into graft failure in just a moment, but it's fibrosis, it's long-term, it's cell-mediated immunity. We don't say anything about antigen antibody, and so the answer is going to be type 4 delayed type hypersensitivity reaction. You typically will get fibrosis just as with this type 4 hypersensitivity, just as you do with granuloma formations. You will get some fibrosis with that as well. And that concludes hypersensitivity reactions. Thank you.